2023 in Malawi. I don't hear some claps. She has been recognized by the Royal College of Emergency Medicine as a William Rutherford Award recipient, and the Society of Academic Emergency Medicine as a Gamma Global Awardee in the USA. Today, she is going to bless us with a talk on mental health emergencies, synergy in emergency medicine. Welcome, Dr. Petra.
It's a great pleasure to be here in Tanzania and just at the bottom of Kilimanjaro mountain. And my pleasure today is to talk about things that we don't talk about most times and we need to talk about. And my important disclosure is that I'm not a mental health expert, but I'm a clinician in the ED that sees patients who come with mental health emergencies. So I think I'm the most appropriate person to talk about things simply and talk about a synergy. So a synergy suggesting that mental health initiatives need to understand the way we can incorporate them into our emergency care systems. And this is very pertinent. So what we're going to do is talk about particular definitions so that we can anchor ourselves when we're talking about mental health emergencies, and then also talk about why we need to consider mental health in our emergency care, but also look at key strategic areas that we need to focus on that are pertinent for us to have a healthy, collaborative, as well as appropriate patient care system for mental health. So we're talking about emergencies, and we know they are life-threatening, require time-sensitive interventions, and so that we are very clear about. And mental health we tend to lump into illnesses, but we know on our continent, illnesses tend to be infectious diseases. We focus on infectious diseases, but forget about issues. So mental health is any time that a patient comes in who has the risk of harm, not only just themselves, but also others. So others, whether it's staff, the family, and other patients in our emergency department, in the ambulance, or in the community, that's a mental health emergency. So which types of mental health emergencies do we focus on? Most of them, we really can group them into two: behavioral as well as psychiatric. And this is very important because sometimes it brings out biases that we use as we're looking at a person who we've labeled as coming with a mental health emergencies. And this distinction has also helped us when you look at mental health response. As we know on our response in crises, in disaster response, we've been very good at developing those particular areas, and we mainly focused on behavioral emergencies that we can work on, but also focus on psychiatric emergencies. So what do we know are the common mental health emergencies that come into our ED? Most of them are self-harm, suicidal attempts, but also we look at behavioral issues that tend to be focused on our biases, that when we talk about hysteria, or among others, that tend to take us time when we find nothing is going on. We need to consider those because they're part of mental health emergencies, and you'll see why I'll talk about them as pertinent for us to not be biased in how we handle them, but actually give a focus to them. But indeed, substance abuse has become very common on our continent, and we need to start thinking about how we can indeed be amenable to substance abuse related mental health emergencies. So why are we talking about this? We are the key stakeholders of creating advocacy towards our health system and what we focus on. Mental health is not just physical well-being, but health is not just about physical well-being, but mental, emotional, and psychological well-being. And this is the hidden epidemic that when you look into various media aspects, you can see, just like we're talking about injuries as a hidden epidemic, we're also seeing that mental health, as we become more aware of it, it needs to be considered because we are all at risk, and Africa has not been spared. And this study that was published in 2021 looked at the burden of mental health issues in 50 countries and said what are the key areas that matter in terms of mental health. Mental health is also for the person who comes in well and they've got issues that we do not elicit. So if you can see the statistics, most of our patients are coming in with hidden depression, anxiety disorders that need to be elicited, even if it's a once-off emergency visit, to help them to become better. And we cannot ignore this because it also translates to how patients indeed will translate to the way they present in our society. So who's affected? Our continent is very young. Most of our population is under 25 from most of the statistics. And they're the ones who really need attention related to mental health. But not only the younger people, we also have the older generation. Geriatric care is is not addressed well on our continent. And we can see that this is causing a lot of economic impact as well. So not just in terms of patient burden, but if we want to be a sustainable, developed continent, we need to understand that mental health needs to be addressed if we want to be economically viable. So this study shows that indeed the DALIs have been affected, and you can see that the most productive years tend to be affected by anxiety, depressive disorders, and we can see that also there are various other areas that have affected the whole community. So what is also the key aspect related to mental health emergencies? People know that us as health workers seem to be focusing more on physical health rather than mental health. As you can see, the perception here, people say that we do focus on physical aspects of manifestation of illness, but are not really more attentive to these psychosocial or mental health related issues. And that's of concern, and we're going to talk about that in terms of strategies. Because where we are working in the emergency department, we know is a busy, very active, very fast rolling environment that requires a lot of attention. So you can see we've been talking about overcrowding. Not an easy place for a mental health patient to actually navigate. So we need to understand that our setups, whether it's in the EMS system, in the emergency department, in the community, should be amenable to how we actually provide mental health services. And so when we look at the design of our EDs, do we consider mental health problems that require some isolation, some need for prolonged counseling, or family support? Do we look at the resources? Do we have social workers? Do we have the pertinent educators that are required? Do we have the pertinent aspects of actually being able to sedate patients, that will help us? Do we have the available protocols that allows our health professionals to be comfortable with an agitated or aggressive patient? But our attitudes and perceptions, you've already seen the communities bringing out the aspect of our bias towards physical illness. Are we advocating for the investment into it? But we all know that emergency medicine is the filter. How are we managing our engagement with psychiatry, with medicine, with social services? So the interspecialty engagement is very pertinent because sometimes the mental health patient can be hidden in the bowel obstruction, complaining of abdominal pain, which may be psychosomatic. So it's very important that we look at the strategic areas in which we can consider will facilitate the synergy for mental health and emergency medicine practice. And that requires us to be intentional. So there are 8 key areas that are coming up within literature. Mind you, we're not talking much in terms of research related to mental health in emergency medicine, as well as also in mental health in general on this continent. So we need to think about strategies in where we can actually make a difference. So the first thing is understanding the demographics. Who's affected? Women are more affected than men, but we do know that particular mental health problems like suicide tends to be more in males than women. How are we adjusting our services to facilitate the demographic differences? Very important. Age specific. Another demographic that we need to consider and understand is very important. But also the aspects related to socio-cultural contextualization. We're African. We walk on the streets. How many of us turn away when we see that guy who's not well dressed or is carrying a big load and you're wondering what on earth this is about? That stigma. I'm promoting it. So we need to focus on improving how we can accept stigma and cultural beliefs. And each year in October, we've got this Mental Health Day, where we should indeed encourage that. But also the actual isolations the isolative behavior we practice in the emergency department for the anxious patient or the aggressive patient needs to be transformed so that we can be able to do so. I always get excited when I come to Tanzania because you speak Swahili and everybody speaks Swahili. In my country, it takes time for me to switch back into Chichewa, which is our national language, because I've been raised on English. English is our language as well, but it does help to be culturally appropriate in terms of language and expression. But also understanding the social networks. No, we say Ubuntu, right? I am because you are. So it's very important for us to understand those aspects so that we can indeed translate them into the pertinent aspects. And I'll talk about socioeconomic factors because that does affect mental health. We need to do this because we can see the benefits of what will happen when we address sociocultural aspects. But when our patient comes through, we tend to focus on the triggers. What has caused the episode? What has caused the emergency? And probably as health professionals in our science, we focus on identifying what are the immediate issues. But the holistic aspect of understanding a person requires us to address all the pertinent aspects related to social history, which is not very well done apart from a few aspects in our history taking, but also looking at genetic predisposition. That's why we talk about family histories. So when we identify a patient with a mental health emergency, we realize we've got key strategies, and our key strategies must be friendly to mental health, but also have value propositions that facilitate an individual to improve, not just for their ED visit, but also their ability to actually function beyond that. We know mental health is a continuum. The acute episodes come in, but the patient is struggling. And our regular ED visits are indeed patients with mental health problems. So we need to focus on how we can optimize these 4 strategies that allow us to look after mental health problems within our emergency care system. Safety is very important, and once our patients have indeed engaged with us in our emergency care, are we thinking of where they should go? We're good at the action now. How are we going to optimize disposition? So it's very important for us to understand that we are propagators of safe disposition. Safe disposition that facilitates a good workup, excluding organic issues related to psychiatric or behavioral issues, but also ensuring that we've optimized the psychotic presentations. Patients who have a mental health condition and require some optimization of treatment to control their acute as well as chronic symptoms. But also to make sure people don't hurt themselves and others, and ensuring that the social support as well as the pertinent community aspects are important. So you see that as health workers, we should be intentional in investing in our training. Not simply for the common things we see, because we do know that in our case mixes, which is also an aspect where we should work hard to talk about the to find the epidemiology in our local settings, but tends to be reported as under 10%. We must be proactive in investing in the knowledge, the attitude, as well as the practice that we need to have to be able to be mental health friendly and appropriate. I also want to bring out important aspects that I personally feel as a health worker I need to read. And because I was preparing this lecture, I found that we complain about systems not working because we don't know our mental health laws. We talk about the aspect of family overpowering our ability to function with patients when the mental health laws have already been propagated for us. So the value of us being able to know the legislative framework that we actually are practicing for mental health is very important. Communication skills need not be emphasized. We're always blamed about not talking properly, on just touching patients without explaining what we're doing. The value in mental health is to engage. Human beings love social engagement, not just electronic or online engagement. And I will be wrong to not emphasize on the need of the health worker to understand they're also human. And this is the reality about mental health. So I, as the provider, must be healthy. And this is the aspect that we invest in the system. So we do know 2 years ago on our Emergency Medicine Day, which is on the 27th of May, we focused on the need for health systems, policymakers, and the various environment, including our community that we serve, to understand that mental well-being is good. A healthy health worker provides the appropriate care. So the aspects of rest, the aspects of understanding our limitations, the aspects of being intentional to say, I cannot handle things today because I've come home with particular events. Do you mind? Teamwork, asking your colleague to say, can you please look after this patient? Or maybe they relate to particular areas that I'm actually dealing with, substance abuse at home, or others where we do and can reflect what we're experiencing on patients and may not be helpful for us. So it's very important for systems as well as ourselves to be able to think of and advocate for pertinent mental well-being at our health facilities. But we always talk about resources. Resources are there. I think Trump has given us a good wake-up call, and we're all wearied from it. But the reality is that resources are there, but they should be balanced in how we actually provide care. So probably we emphasize on malaria, we emphasize on cholera, we emphasize on others. How much of us, when we sit on our budget, making our budgets, or we're advocating for investments in mental health, think of the need for us to invest? And as we've said, Trump is telling us we're not doing well. Africa can see how much we're investing from our national resources. We need to do better if we want good health systems. And how can we do that? Well, we need to learn advocacy issues, that investment into mental health is investment into health systems. The taxation we're looking for injury care, I'm another advocate for injury care, where we're looking for taxation, must be considered that it also contributes to mental health, and they should contribute to mental health well-being. And why is investment in mental health important? Because mental health is not just about healthcare, popping pills, among others. We need social therapy, they're talking about interpersonal therapy that requires investment in transdisciplinary modalities of care, looking at how the community deals with mental health issues. So the investment is not just for drugs, but it's also the various modalities of care. So it's on that note that I would say the synergy of mental health, not only as emergencies, but with the continuum of care into emergency care systems, requires the understanding of the situation we're at, the gap that we have created or exists, but also the need that we need to address. Not to try and conquer the whole Mount Kilimanjaro, but really take steps at a time. How do we do this? By harnessing integrative, universal access healthcare strategies. So we do not realign to say, let's give so much money to mental health, but we ensure that everyone is looked after. As we know, mental health is multifactorial. But investment in key strategies that will affect Tanzania, some of them will affect Tanzania more, others will affect Malawi or South Africa or other key areas within communities in Tanzania will require particular investments that may be different in different strategies. So it's on that note, I hope I kept my time, that I will keep quiet. And hopefully I have stimulated your food for thought, and that indeed we will have a better synergy of mental health into emergency care. Thank you.
Thank you very much, Dr. Molinda. You stressed about the mental health, and especially in emergency, and even our community. Yeah, we have seen the young generation and the young adult generation being more affected. So the physician well-being is promoted, and a stepwise approach into solving our challenges. The next speaker, I would like to welcome first, before all, I would like to recognize the presence of our guest of honor, Daudi Msasi, who is the director of the pharmaceutical services and from the Ministry of Health, and also to recognize the president of Emergency Medicine Association of Tanzania, Dr. Juma Mfinanga. You're welcome. As the introduction will go later. Next speaker is going to be Dr. Pokei Olisubisia, who is anesthesiologist in Dar es Salaam, Tanzania. Dr. Pokei Olisubisia, who is an MEd, FCTS, ACC, CMS, Telangana, FCA, EXA, and MBA, is a consultant, anesthesiologist, and critical care consultant with more than 20 years of experience practicing medicine, training doctors and teaching medical students in the United Republic of Tanzania. He served as the permanent secretary of the Ministry of Health in the Tanzania Ministry of Health, Community Development, Gender, Elderly, where he oversaw country's efforts to provide equitable health services that are of high quality, accessible, affordable, sustainable, and gender sensitive. By then it was quite, it involved more than 2 or 3 ministries. It was quite a task. Thank you for your service. He also served as the High Commissioner of the United Republic of Tanzania to Canada. Dr. Pokei served as the president of both the Society of Anesthesiologists of Tanzania and still serves as the College of Anesthesiologists to the East Central and Southern Africa, CANEXA, of the EXA College of Health Sciences. He is also a visiting lecturer at Muhimbili University of Health and Allied Sciences and Hubert Kairuki Memorial University. He earned his undergraduate degree in medicine from Muhimbili University College of Health Sciences at the University of Dar es Salaam, where he also completed his postgraduate studies and residency in anesthesiology and critical care. Additionally, he earned a master's in business administration from Zumbe University, completed his internship in internal medicine at Mbeya Referral Hospital, and received postgraduate clinical training at the Royal Perth Hospital in Australia and Care Institute of Medical Sciences in India. He currently works at the Jakaya Kikwete Cardiac Institute in the country as a cardiac intensivist after completion of his tour of duty abroad, and recently he was appointed by Her Excellency President of the United Republic of Tanzania, Dr. Samia Suluhu Hassan, to be the Executive Director of Muhimbili Orthopedic Institute. Today he will present capacity building, the forgotten gap. Welcome.
Good morning, ladies and gentlemen. I'm saying good morning, ladies and gentlemen. Okay, the boys and girls, habari za asubuhi. It is a serious privilege to be part to this great meeting that has been convened in this city of Arusha. I was not very sure, Brother Msasi, whether the moderator was talking about somebody else, because I think that hype was about some other people and not me. Yeah, I think this is what keeps us going and brings us together. There's supposed to be a screen up here to make it easy for me to present, but now I think I got to learn to speak from this angle and look at the slide so I don't leave you or remember to forget what I want to say. But I'm delighted to be in this audience because it is in addressing challenges that we agree on the best way forward. This country has a big history, a lengthy one too, that best subscribes to the theory of sine wave, with the opportunities of attaining peak success, but also challenges that have made us look like we do not know much of what we are supposed to do. A week ago, I was privileged to speak in a certain function where we were celebrating the great strides that we have made in preventing maternal-child health, or maternal-child deaths, not health. And I made reference to several facts that were true of the situation in this country. The first one was we had done a survey a long time ago that indicated of the women in the reproductive age, every 100,000, about 550 will be dying of childbirth-related complications. That equates to a mortality rate of about 556. Now, while in office, I asked my team whether that was true. The reason for that question was born of the disparity in the actual numbers that I received every month, indicating those women that had died in relation to the 20,000 that would have amounted to something like 1,800 a month. So we realized something was wrong, and we went to the National Bureau of Statistics. Madam Albina Chua was there. I challenged her and asked her, where did you get this data? Are you aware that this means 20,000 women are dying every year in this country? She said, indeed, but I need to be very honest with you that this data was born out of our demographic surveys. I asked her which ones. Were these historical? And if they were historical, how were we able to sustain a growth rate of about 1 to 2% per year in this country? And the government has invested a lot in the health sector. She told me, okay, we are employing the sisterhood method of data collection. And that's where the problem started. Because when you employ the sisterhood method, all you are saying is you go to every household and ask them, has any woman died of childbirth complication in your family? And that question is very open. Whether they died before the Germans came to this country or they died 2 years ago, the answer will be yes. And truly, when you collate that data, it is not surprising that the numbers were that huge. And so Dr. Makwani and the team went down to seriously look into the data, and Albina Chua and us agreed that truly the number was not that big. I said the number was not that big, meaning that still we were losing some women in our society. Now, if we were losing these women, what was the reason? So we went out and looked at the actual environment. And Msasi would remember that teams went all over the country. And we realized there were many problems. The best way to address any problem in the health sector is not by burying your head in the sand. It's by facing it head on. Now there are two options. You either crash, die, or the problem crumbles with solutions. In this country, we've been privileged to have solutions to any of the problems that we have encountered, especially in the health sector. So, for this talk to make sense on the gap that exists in capacity building in the health sector, I thought it would be necessary for us to make use of the building blocks of a resilient health system that were brought out by the World Health Organization. Now, in my computer, this slide gave me very big fonts. But I don't know the IT industry in this hall, so please accept my apology for the small font. But there are 6 and you know them. And I deliberately decided to bolden what we are talking about. Now, leadership and governance goes without saying. This is where policies come from. If you don't have brains that can think through a situation and then agree on the best way to address those challenges, you have decided to fail even before starting. It's necessary that we have people that are learned. It's necessary that there are people that know, but it's necessary that we have people that can walk the talk. I was privileged to do a similar talk like I'm doing here before another body of physicians in Dar es Salaam a few months ago. I told them the only free thing in this life is ignorance. You didn't know that, Farida? You don't need to go to school to be ignorant, do you? Yeah, you just need to remain where you are, Emma, and you remain ignorant. So we need to invest in leadership, and we shall talk a little bit about how our education system has not invested enough in that particular area. Then the other one that is provided there, the health delivery systems, and I just put infrastructure. We've done very well in this country. And because I don't come from the President's Office, regional administration and local governments, I did not want to mesmerize you with figures on how many health centers, dispensaries, district hospitals. Talk a little bit about regional hospitals because that's one area that I invested a little bit before I left the Ministry of Health. But what I'm trying to say, we put in a lot of money, even in areas that never thought will have health delivery units. We made sure that they were built. And currently, 80% of our population, and for those I am told there are about 15 nationalities in here who come from other republics except the United, we are about 65 million human beings in this country. So 80% of them have a health facility within 5 kilometers of their radius, meaning that it can be accessed so easily. So we did well. But now putting up infrastructure is one thing. The next that should be discussed here is the health commodities. So health commodities comes down to medical products, vaccines, and technologies. I just want to discuss them together so that the thought process flows. So we built, but we also equipped. Health centers, dispensaries, district hospitals, and regional hospitals. The regional hospitals, a majority of them currently have radiological equipment, the CT scans, and the zonal referrals, and the national have MRI to complement all these facilities. And then you go to health information systems. You need that, because the world today is riding on the back of information technology. So for your system to be resilient, for your system to respond to the need, you need to invest in health information interventions. That we've done very well, because each district hospital in this country is connected to the fiber optic network that connects us to the world, but also to each other. I just came from a meeting where we're looking at how best to make use of the capacity that we have in our country of the information technology, the eager government staff. But the problem of doing all these things is multiplied when human resource for health is in short supply. Now that's a serious problem, because you create a pull factor, health facilities, health commodities. The next thing that your clients would require of you is the presence of trained, well-informed human resource for health. You call it capacity. Now, we did not do very well. And the people in this audience from this republic will testify to the fact that there are many places where we have ghost structures that are waiting for the experts to populate before they start giving quality services. And I underline, I bolden, I capitalize the word quality. Quality health services. So this conversation is not complete if we do not address what are the challenges that we have that will require for the human resource for health to be trained like we need in this country. The diagram that is projected gives us, in a nutshell, of the major diseases that have received serious funding from the world. HIV/AIDS, malaria, tuberculosis, and reproductive, maternal child health complications, together with water and sanitation. These are not the only diseases. In a country like Tanzania, where we have all sorts of climates, from desert-like to the coldest places on top of Mount Kilimanjaro, you know we can have all those diseases. But let's agree, for the sake of this session, that we divide those diseases into categories: the infectious and the non-infectious. And we are catching up with the Western world because of the choice of lifestyle that we have picked. So the non-communicable diseases are a serious problem. Like the guy that introduced me to this audience about the work that I did before going to the Orthopedic Institute, I was at the Cardiac Institute where Said and I are working. Yeah, it's true. Coronary artery diseases is on the rise in this country. And many others of that kind. Obesity, talk about renal diseases, orthopedic that results from us carrying more kilos on our frame than we were meant to. Diabetes is on the rise. How many of us are well enough endowed with information to manage all these diseases? That question is to be answered by each one of us individually. The point that I'm trying to stress here is this: we have a spectrum of diseases that calls for knowledge acquisition from time to time. These diseases seems to be very, very dynamic. They are not standing still, waiting on us. With the population base that we have in this country, and the youth being more than those that are as old as I am or even more, they are also catching up with the diseases that in the past never used to be cited in the young. Now, because of this need, there is a need for us to agree on the best way forward. Now, I'm going to share with you some principles that I believe need to address the gap. They are not exhaustive, but I believe they are a stimulant to our thoughts to help us embrace some and even make better on that which I will not have mentioned. I will spend some time addressing what the advancement in technology has done or is doing to help us bridge the gap of information that may be in possession of our persons as we discuss together. So, we need trained people. We need people with information. Before a majority of you were born, we had casualty departments in most of the hospitals. So where Juma, Saidi, and the rest are working at Muhimbili, it was popularly known as casualty department. So it was meant to handle casualties. But then we realized that people who come to hospital, very few of them will have resulted from casualties. Because in casualties, you need to define them. Are they motor traffic accident? Are they product of civil unrest or wars because of what is happening around the world? And a majority of these things were not the reason why people came to hospital. Then it was discovered that when we fail to triage patients at the entry to the hospital, we have initiated a cascading flow of events that eventually will deny longevity in these people that come to our institutions. And because of this, with support from well-meaning friends, by the way, that preceded the coming of Trump. Those days were other presidents in America, not the current Trump. So they supported us from that great republic. Some of our experts went to learn there, and some of their kind came and taught the first cohort that turned out to become the teachers. So why was this necessary? Bullet number 1 addresses it. Maintaining standards of care. In our environment, I don't know about other places. When you meet people talking about a disease, and Farida, I'm talking about ignorant people, yeah, sipping a cup of coffee, and they want to tell you how serious a virus causes malaria. And several people are listening carefully. This virus that has defied medication and kills people because of malaria. Yeah. So we need people with information to tell them that actually the Plasmodium species has never been a virus, neither is it thinking of becoming one anytime soon. That can only come from people that will have sat in a class and taught and listened to lectures of parasitology and understood that Plasmodium isn't just one, but there are several. Some are in animals and some inflict human with diseases. Our society is full of myths. And I need to stress here, because if we do not educate our people adequately enough, they'll be part of the myth syndrome. So we'll be running campaigns to immunize children, and they will say these vaccines can sterilize the young girls. I remember this was the case in the 90s when tetanus vaccination was a campaign around the country for the ladies that would be pregnant not too long from that time. Even priests and pastors and imams supported this myth. And then there are congregations, there are women that had 5 or 6 children, and with every pregnancy, these women had received immunizations against tetanus. So we need people with information, yet polite enough to dispel those myths and this is what the second bullet means. But we also need to address existing needs. Recently, we had a Marburg outbreak in Kagera region. How many of us come from Kagera here? No, I don't want to stigmatize you. I just want to put this in context. All right, I didn't see any hand coming up. Don't worry, just keep it down. All right? Marburg disease is not endemic to our country. So it is a sporadic occurrence that we come across from time to other time. It's been twice now. But we also had HIV that came in the 80s. We did not have this disease historically. And then there was the pandemic that recently swept around the world. These require people to go back to school. So they are equipped with abilities and knowledge to address them. We need to go back to learn. We need to build capacity to address needs that arise and what may have changed the paradigm, and also for what emerges. Now, the training for health delivery system in this country falls in those categories. We have the primary that starts with community health workers and people that are going to work in dispensaries, health centers, district hospitals, regional hospitals, and the tertiary ones like where some of you are working. The least trained in the medical field are usually deployed at the base. I am not sure truly if that's the best way to do it. But since it's worked for a long time in this country, I will buy it. The best teacher for a child is the best trained to start them in school. I wish the same principle applied in medicine. But it helps us to filter the not so sick. The only trouble when misdiagnoses are made, then patients tend to suffer big time. Like a patient that recently came to our facility with a big lump in the breast, but a broken neck of femur. The major concern for her was the broken hip joint because she couldn't walk. So when she was being reviewed, she was told, this is a major problem. She said, no. That's not what brought me to hospital. And please stop addressing this problem. Just address the hip. And there has been a big fight. Msas, I hope you've heard of that lady. Serious problem. Okay? So we need to address that because at times when we miss such diagnosis, these patients will tend to suffer. Last, we need to appreciate and embrace the most recent advancement in learning and training, and I mentioned there remote learning. So why? Because there are specific neglected areas, soft skills, crisis management, interdisciplinary collaboration. We lack of focus on emotional intelligence and communication skills that are very crucial. The doctor from Malawi has reminded us about mental health. Issues that we live with and we pretend that they don't exist, and people burn out. And so absence of structured programs for continuous professional development, and the reason for this is because of the ever-changing landscape of practice of medicine that we need to keep abreast with such knowledge. When we don't do those things, the next becomes the results. So, suboptimal patient outcomes, increased staff burnout, higher turnover rates, together with a great potential for increased medical errors and compromised patient safety. Suboptimal treatment of patients results from people that are not as informed. Now, what are the most likely impact on these challenges? The first one is the team dynamics, patient care, the cultural competency, together with patient-centered care. Now, external factors that affect training in many places or capacity building, then becomes budget constraints, policy changes, and the ever-living resistance to change. I'm not sure if you are coming from the same base as the person who invited me comes from. So I will ignore you, you are not. And please don't bring another one. Thank you. All right. Before we embark into any training program, we need to do assessment. We need to be realistic. And how can this be done? We need to assess by asking what is needed to be fixed. You don't just come and do everything because you don't have time, and I doubt if the resources will be available for that. So surveys, interviews, and performance audits. These must be done regularly because they will point out to areas that need attention. If this gap is to be addressed and closed anytime soon, then those must be done, without forgetting to involve the staff in question, who would tell you what their felt needs are, so they create a momentum for a push factor into the training, and you create the pulling factor by availing resources and time for them to train, without forgetting data analysis, because without data we have no right of saying anything. This is meant to show us some of the facilities that offer training in this country, beginning at Muhimbili to the many colleges that are there. And my brother, you are right in squinting your eyes like that because it wasn't meant to be this tiny. But again, I already submitted my apology. The reason I put that diagram there was to address the fact that at one point we only had one medical institution that offered training for doctors in this country. But now there are many, and there are so many colleges that offer the training that can provide us with middle level and the lower level clinical service providers in our country. Now, there are several ways that you can train. Simulation, I do not need to repeat so many words. It's one of the most relevant avenue that you can train so many people repeatedly without being scared of tiring the patient, like we used to do when Hutchison's clinical methods, or the textbook that we carried with us every time we went to the ward and read before doing anything. With the simulation, you just read and do, and your colleagues can always say this can be done better than what you have done. Crisis management, decision-making skills, and team dynamics are enhanced when this is employed. I do not need to overemphasize the fact that we need to break silos. What is done in critical care but also happens in emergency medicine, it happens in anesthesia, in internal medicine, pediatrics. These should be taught together. It will save us time and resources. We need to agree on how to synergize the teaching or training process so we reach more people for less resource. If each discipline is going to cloister themselves in a room and say we are going to learn by ourselves, of ourselves, us, it's going to be very expensive. So we need to provide space for interdisciplinary training. And the list there, this set of slides will remain here for those of you who want to pick some. We need to share our resources to enhance that. But remember, we get trained to, when we work together, learn together, the conflict that would have resulted from different approaches to thought processes will be minimized. We create patient-centered care, and again, we create space for innovation and the solving of problems in caring for these patients in our environment. I think I've mentioned about the efficiency and the resource utilization together with professional development. This is one area that we need to be awake because we know it's happening in the world now. The e-training, virtual reality, mobile apps, online resources. These provide flexible learning opportunities, and there is potential for artificial intelligence and machine learning to personalize training experiences. Now, a majority of us will go to a class and we will sit and the teacher will teach, and when an exam is given, Lo and behold, one gets 90% and the rest of us at 51. So that means our ability to retain information is different. With artificial intelligence and machine learning, the program will address those areas that you will need to concentrate on. Because the fact that your colleague got 90 and you got 51 doesn't mean that you are ignorant. It simply means that the questions that were asked at that point favored that individual with the knowledge that he had or they had, and not you, because you did not invest adequately in that particular area. So never look down at your colleague and think they were fools because they didn't get 90% that you got. And the majority of the time, some of them would stand a better chance of scoring better than yourself. Now, by the way, I'm talking to myself, if you didn't know. All right. So this is the information that I wanted to stress about the artificial intelligence and machine learning. 3 major things: adaptive learning platforms, data-driven insights, real-time feedback. This is what we need most, so that you know in real time what are the areas that require your improvement. I'll be taking part in a certain program for training the trainer. We are doing some pre-training quiz. So some of the questions that you answer will inform the instructors on what areas they will need to concentrate in helping you to do better if you're going to train other people to train the lower cadre. I think I need to stress on predictive analytics. The beauty about machine learning is it can tell ahead of time which direction you are taking. And so instead of you going that direction and hitting against a wall, it will prevent you from doing that, and therefore saving on time and the brain resource. Instead of trial and error, then that becomes the real thing, and it enhances engagement. And because machine learning is not a human, there's never be a time that they will laugh at you. There's nothing that irritates when you're trying to learn something and people laugh because of the slow pace that you are putting into understanding. With machine learning, that's not going to be the case. Saidi, this does not mean that our role as instructors is going to be obviated. No, but we shall instruct our trainees to go, get exposed, and we shall set the exam still. And they'll still acknowledge our presence. The only thing that is going to make a difference between those who are going to survive and those who are not going to survive in the coming era is whether we are AI savvy. No job is going to be taken away. But for those who will say AI is not for me, they are saying already that I am not going to be in the labor force of the world that is coming. So let us embrace the process now, so that when it's enforced, we are already there, and then the gap will have been filled. We need to put in dynamic and robust feedback processes. None of us is perfect, and this is going to help give us areas that will require more attention to rectify, for our teaching, our training to be efficient in the environment that we find ourselves in. And this has to be continuous from time to time. The program that I will be taking instructs that trainees must receive their feedback after every session. I said every session. You don't have to wait till the semester has come to an end before you tell them you are very weak in clerking for patient history. You are very weak at interpreting x-rays. You are very weak at this thing. Every day you need to provide that feedback for them to go back and start inhibiting that wiring that will make them keep within themselves wrong habits and attitude. This is one area that all of us need to embrace. You just get appointed to lead an institution, and the daktari, that's where you're going to start learning. Chairing meetings, conflict resolution, time management. You call for a meeting that's going to begin at 7, people don't come till 10 o'clock, and they were coming to the same meeting that you invite. If only our training modules provided space for leadership, I believe the way we deliver would have been very different. You know, there are people that are just rude, not because they were meant to be rude, just because they don't understand that when we work together, we need to accommodate each other's interest. If we are to accommodate for each other's interest, we need to respect time and be ready to comply. A class is supposed to begin at 9. They say, no, the teacher is always late. Why? Because the teacher was never taught. So this becomes a vicious circle. But with the kind of heads that I'm looking at here, I believe this is history. I want to believe that I have a group of people that live in this place. When they say a meeting is convening at 7:30, that's when the meeting begins. That's not when people start coming into the venue. We need that in our leadership skills. Leadership training must be enforced everywhere we work, because it is the first step in conflict resolution. If we do not invest in leadership skills, we are investing in anarchy. Trial and error has no place in the establishment of working and adaptable, the resilient working conditions. Resource allocation, well, it's a little bit of politics. When you have the resources, then you need to be careful to know that the resources can be time, funding, personnel, training programs. Remember to prioritize training in budget planning and resource allocation, because sometimes we forget and we complain when we are not given that. Future directions, we need to be innovative by making sure that we personalize learning paths and we integrate the artificial intelligence and the global collaboration and knowledge sharing in training development is something that we need to embrace at all times. This has been my privilege talking to you. God bless you. Thank you.
Thank you so much for the talk. It was worth listening. Coming up stage to introduce to you Professor Petra. I'm sorry I can't pronounce the surname. I will have her pronounce it herself. But just one thing that I would say, in 2012 when I walked into the ED of Emergency Medicine Department at Muhimbili, at the young registrar, that's when I heard the name Petra for the first time, because I met a group of nurses that made me fall in love with emergency medicine, just the way you would work with these nurses. So she's the president of Academy of Nursing of South Africa. She's a fellow of the American Academy of Nursing, president of the Academy of Nursing of South Africa, and a member of Academy of Science of South Africa. She is actively involved in the African Federation for Emergency Medicine. She has worked with research and education of the professionals, primarily nurses in South Africa and Africa for over 25 years. As I said, most of the emergency nurses in Tanzania, she is the mother. She has an experience of over 25 years in the area of acute emergency care, and she is the editor-in-chief of the International Emergency Nursing Journal. Today, she will bless us with a talk that says, Career Pathways for the Clinical Scholar, Securing the Role of the Clinical Nurse Specialist. Welcome, Professor.
Thank you so much. I'm also going to go to the side so I can see what's going on. And thank you to the previous speaker who gave such a wonderful overview, and I completely concur. If I can offer one additional thing, is the transdisciplinary nature that the collaboration should be affording as well, because doctors, nurses, pre-hospital, everybody needs to be working together to solve all of these problems. Absolutely. So I'm going to take you through, I have a lot of pictures and things, and just to talk a bit about clinical scholarship and the nurse scholar, but this applies to medicine just as much. I do lots of work with other health professionals, and a lot of the medical doctors have exactly the same problems, the physios, the OTs. We suffer from the same things. So in terms of this talk, though, I will obviously just focus on nursing. So why should nurses do research? And this is what people ask me all the time. But nursing is quite a unique profession. And it really does offer this holistic, compassionate approach. And it's this authentic window into somebody's life. We have a nursing meta-paradigm that is very comprehensive and really looks holistically at the whole person. And I think the value that nursing brings to research is immense. So nurses have a lot of clinical practice and know-how that if we can instill that in scientific and research skills, it really can do a lot to further contribute to the science. And a creation of a scholarly mindset in order to be able to do this is essential. So by conducting research, it is the nurse specialist is able to become more efficient, more effective, and to find these safer ways to look after their patients. And nurses are actually known as the hackers of the hospital. If you're ever looking for a solution to something, you need to ask a nurse, because they can always find a way around something. And I can see some people have been asking nurses here, busy nodding their heads. But being able to put that into scholarly work is vital. So I know we all know this wonderful framework from WHO that colleagues of ours all put together. I just want to put it to you that at every single point here, nursing is involved. So you cannot sort the healthcare system and you cannot move forward without nurses. And that's just something to sink into all of our minds. Nurses don't just appear at one point in this picture. We are everywhere. So what are the challenges for building capacity for these nurse specialists and for improving evidence-based practice in nursing, and with our specialist nurses particularly? So we've done lots of research in this kind of area, and one of the PhD students of mine did a really nice study in Lesotho and was looking at professional isolation, and specifically amongst emergency nurses. So we train these specialist nurses, and then we put them out and we say, go practice your skills out. And these nurses are saying, I feel like an island because I'm the only specialist person there. And nobody else really understands what I can do, the language that I'm using, the way we should be doing things. So we then put this person out there and they're feeling all alone and unsupported. Another student of mine was doing some work in Malawi, actually, with child nurses. And a similar thing, these nurses would all come, get very specialist training, go back to their countries to be able to now practice as clinical nurse experts. And what's the first thing that happens? As soon as they go back, they get pulled into other things. People say, you have specialist training now you must go into leadership. You must manage the ethics committee. You must do all other things except the one thing that you went there training to do. And these nurses are saying, we're pulled to four corners. We don't know where we need to go. Everybody wants a little piece of us, but that actual expertise that we went to go and get trained for, that's actually the one thing we cannot do. If we also think about nurses doing research, there are thousands of barriers. These are just some of it. You see, I do like AI, and I use AI to make some pictures for me. But it also was plotting all the barriers for nurses, and there's tons and tons. And these are the same for medicine. We did some work in South... Oh, sorry, must I go back? There we go. I'll wait till he's ready, because I was very impressed with his slides, and I was taking pictures, so if he wants one of mine, you know, fair's fair. We also did some work in South Africa. We were asking people about the barriers. It's the same thing, you know, support, funding, reward mechanisms, time. And we often sit, my students especially like to say to me, oh, this is Africa, it's an Africa problem, we don't have time to do things, it's very hard for us. We did some work with colleagues that are in the UK. They have exactly the same problems. Doesn't matter where you are. These problems are similar. So I think one of the major problems that I find with research is we need to make research visible. And what I mean by that is that we need to show people the concrete practical value of research. Otherwise, a lot of the times when I go around talking research, I just see people's eyes get glazed over and they're not interested. Like the speaker before was saying, he was telling us all the stats and all the interesting things. It's the application of research that then makes it real for us. So research really helps us to expand the knowledge of our speciality. And especially for these specialist nurses, it really then helps to perhaps introduce innovations and elevate the profession. I do a lot of work around trying to develop clinical scholarship. So really trying to get the people at the bedside to do the research, to do the work, because those are the ones that really can have the biggest impact in then being able to change practice. It's not people like me sitting in my office. And so I like to just remind us all around scholarship and how it's defined by the research that's conducted, and it's central to the advancement of knowledge and the contribution of the profession. So obviously I'm very interested in it because I want to serve to further advance the profession of nursing, but it's the same for all of our professional groups. And ultimately, by improving our scholarship in nursing, we are aiming at improving and advancing patient care, which is what we are all here, hopefully, to improve and to do. We know that scholarship is an important thing for us to think about in Africa, because it is about helping us to change the nursing culture. And we do need our nurses to question more, to be inquisitive, to reason around these specific matters, and to think about our routine nursing practices and say, why are we doing it like that, and what can we do better? And that used to get me into lots of trouble when I was training, because people hated the fact that I was always asking why. But that is what we need to be doing. And nurses need to be recognized as frontline healthcare providers and leaders. So often nursing and nurses are invisible, but none of your healthcare systems could work without us. And in fact, I was at a conference recently where they were showing all these fancy machines. It was a critical care conference, fancy machines. The reps were saying how they're targeting the doctors to use these machines to ventilate the patients and do all sorts of things. And I said to them, well, what about the nurses? And they said, well, what do you mean? We're targeting the doctors. I said, you know, if there's no nurses, there's no units where you can push your little trolleys in with all those machines, and then there's no one to be plugged into your machines. So what are you doing to think about that part of it? And they said, oh, yeah, that's true. Nurses are very important. But unfortunately, we have to do a lot to make sure that we stop being invisible. With some colleagues, we had a look to see what's happening in Africa, and specifically around emergency nursing research in our region. So we undertook a scoping review to have a look. And we were really just looking at general things, what kind of, I see what you mean about the IT changing your slides. Yeah, my slides font's also been changed. Yours went too small, mine's going too big. But we were really just looking at the publication trends and then looking to see, what kind of research was being done and by whom. And that's just to say, was looking at sort of nurse researchers who were involved in doing the research, research that's been done on the nurse, and also nurses involved in multidisciplinary teams. And it was wonderful to see, actually, because I've been around for a long time, and it's wonderful to see how that has gone so high in numbers. If we look at where we started in 2000 and where we are now, it's wonderful to see. And I've just sort of highlighted the fact that I think the African Federation of Emergency Medicine and the subsequent journal has been instrumental in really providing a platform for African researchers to publish their work. This is also just to see all the countries where publications are coming from, and the different types of research, because people like to often say about nursing, and they say, oh, you're all just doing qualitative research, and that's actually not true. That's the reason why we were specifically looking at these methodologies. And then this is just to highlight just a few of the nurse researchers with excellent research here in your own country. And you have lots of nurse researchers, emerging scholars, some are very established scholars, and it's wonderful to see in this country. And yes, some of them are my ex-students, and so I'm very proud, obviously. So we can see that there's a large number of publications, and that much of the research, however, is still at a descriptive level. We're describing what's happening, and being able to move into interventions and evaluating interventions is where we need to be heading, as well as having more multidisciplinary teams, because if we want to look for funding and get money to help us do that, that's where we need to be moving to. The focus of a lot of these publications was really around education, but I'm sure that has a lot to do with the fact that we were, starting up emergency nursing as a profession in all these countries, and so it makes sense. Many of the publications were also limited to in-hospital, and things like out-of-hospital care, management, prevention were quite limited. So, on being a research and a clinical scholarship model and mentor, I'd say that in Africa we actually have a large number of nurses who are doing this, and just sometimes they're very quiet about it, so people don't know. The WHO Basic Emergency Care course has really highlighted this, and there's lots of nurses that are involved in this. I believe it's very important to have nurse champions, to have those people that act as role models, to act as mentors. And here in Africa we have lots. It's just sometimes, as I say, you don't know who they are, and some of them are very quiet, and I have to go calling around, dragging them to come out. And some of them I was just meeting yesterday. So I'd say that being a mentor is a very important thing in Africa. And as a mentor, one of the major things is really trying to remove obstacles, because there are so many obstacles in Africa. It really is about us trying to facilitate and make it easier for mentees, those younger ones coming up, to be able to then move forward. We've done some mentorship initiatives to support emergency nurses, and we know that there's lots of many challenges, and often it's around engaging and maintaining contact, about being geographically isolated, and this interactions between colleagues and between different professional groups is also sometimes challenging. I wanted to just tell you a little bit. We had a project that we were doing in South Africa. We called it Drill, and it was to develop high-quality health researchers across a number of professional groups, and it was to really address healthcare challenges in South Africa. This was US money before Trump said we weren't allowed to use it, so luckily our project finished just before. And just to acknowledge my co-PIs. So what we did is we were targeting these early career academics, and we targeted researchers from the Department of Health that were working as clinicians, and also some academic staff. And it was really based on mentorship. We built communities of practice around these fellows. We promoted their research knowledge, their leadership. We helped them with career guidance, because a lot of people are really unsure about how to move themselves forward and how to navigate around obstacles. And we helped them to look for funding. So this is just some of our recruits. We actually had a lot of females. And we achieved incredible things. This is just, it might be a bit too small for you to see, but we had, because it extended, it was about 7 years, just because because COVID gave us another 2 years. We had over 484 publications, 41 grants, and of those, 14 were global grants. Lots of promotions, lots of supervision of students. And what we believe, huge amount of our success was the way we mentored these people. Okay, we provided them with a group of highly skilled, quite prestigious health researchers that could give them the kind of information, the kind of knowledge they needed to be able to navigate through their career pathway. I also believe that we need to demystify research. Usually if I start talking to people about research, and often especially nurses, I think they all have a case of research phobia. And I think that unfortunately again goes back to problems that we have made in the way we educate our students. And I think that's across the board. When people teach about research, they usually like to use these very big words that makes everybody very confused. And then everybody thinks research is so hard that you just can't do it. And it's not true. It's like anything else, you have to just learn how to do it. And I usually use this with my students and with other people I meet, that it's about starting simple, about being targeted. Have a team, arrange a team, and don't arrange to do research with people that know less than you. Okay? Have a team with variety of skills. Do something that's relevant. Don't do something that everybody else does or seems to be the flavor of the month. Go to your clinical setting and see what the problems are there and do something that's useful. And then have timelines. Don't end up being someone who started a project and 15 years later it's still going on. That won't be any good. For us, here in Africa, I think, as I said before, the fact that we started up a journal that was promoting African scholars was very useful. Again, as I said, mentorship, I think it's huge. And funding, we have to really look for funding. And yes, Trump is making us, as Melinda was saying, we got to start looking, and we got to see what we can do to try and support ourselves with the research. Just a plug for the journal and for AFEM. So if you don't know, please go have a look on the website. They're both excellent resources. I'm plugging my own journal because The journal I'm an editor of, it's a UK journal, so I'm really trying to do my bit to help and provide an opportunity for researchers from Africa to be able to access such international journals. So on the way forward, I think it's important for us to think about the fact that there are different types of scholars. You have a research scholar and you have a clinical, a practice scholar. And both are extremely important. So doing your PhD is one thing. That's what makes you a research scholar. You generate new knowledge. But for us here in Africa, I think we really have to work on developing this practice scholar. And that's for us across the board in health. I asked ChatGPT to draw an image, create an image of my career. So I'm not sure if I should be happy or sad to see the picture it made. It's a very windy road, and I can completely agree with that. But given my path, I can give you a few tips, and I would always say, get yourself out there. No one's going to come and find you when you're sitting in your office or you're sitting in your emergency department. You must move. And it's wonderful that you're out here collaborating and networking with colleagues, so well done you, but keep it up. Develop your focus area. You know, your research focus or your practice focus is not emergency care, it's what you're doing, but what within that is your particular focus that you want to work on. Get mentors. Okay? Don't choose people that are going to steal your ideas or people that are going to belittle you. Choose people who are going to support you, people that you trust. But you need to find them. And you'll find different mentors at different times in your path. Work collaboratively. It's wonderful to work with people who have completely different ideas to you. I do a lot of work, obviously, with doctors, with nurses, with different other health providers, but I particularly like it when I work with people like philosophers or engineers or, the data science people. They're quite a strange bunch with all the AI and machine learning. But it's so wonderful because you really do different things. And I would say, make sure that your focus then is clear, that it's on improving care at the bedside. And keep looking for opportunities because they are there. You must just open your eyes and keep looking. You just never know where you find something, where you just meet the right person, where you have a wonderful idea. And then I'm just going to suggest that maybe you take some learnings from a frog. We're in Africa, so it's good for us to appreciate our nature. So if you know the foam nest frog, the tadpoles drop down from the nest and they need to drop into water to survive and to grow to become a frog. So you must think about where your nest is, okay? So if you make your nest up there and you can see there's no water, it's on a busy road, then you're setting yourself up for failure. So think about how you are setting yourself up to succeed. And where are you putting your nest? Okay? And remember that there will be obstacles. There will always be lots and lots of obstacles. But you can get past. And that, it always looks like everybody else is having a good time and it's easy for them. But it's not always what you see. And thank you very much for your time.
Thank you, Professor Petra, for your talk. Professor Petra emphasized on the engaging the clinical specialist nurses on research, training, and mentorship. If you can't do alone, you're afraid, invite your colleague, and let's solve the problems through research. Our next speaker is Professor Stephen Dunlop. He is an emergency professor from Minnesota, USA. Prof. Stephen Dunlop is an attending physician at Hennepin County Medical Center, Minnesota. He's an associate professor of emergency medicine at the University of Minnesota. He's also the director of the fellowship in global emergency medicine with an appointment as an ASTMH certified global health cause co-director focusing on education in ultrasound, trauma, and simulation in resource-limited settings. He has years on the ground experience in East Africa, focusing on education, research, and system development in acute care systems. Today, Professor Stephen Dunlop is going to present on seeing beyond the shortage, the importance of the systems in the emergency department. Welcome, Prof.
We'll see if they have my slides. Otherwise, maybe I won't even have to turn around. I can just talk to you. First, I guess I want to start with saying I am so honored to be up here. The slate of speakers that I'm following were fantastic, and I'm pretty humbled. I have a bit of an imposter syndrome, I have to say. And secondly, I want to thank Peter and the entire team, Dr. Mabula, for putting on this conference. I mean, if you look around the room and think about what's happening over this week, the 3 days of pre-conference and the 2 days of conference, thinking about 15 years ago, you know, when the specialty of emergency medicine literally did not exist in this country, and here we sit today with a few hundred colleagues all thinking about emergency care. I truly think it's something special, and for us to realize what we're being a part of, and for that I'm truly honored and humbled to be here. Hey, there it is. Does this clicker work, guys? Do I get to use this? Okay, perfect. Okay, so in order for this to work, one, I understand that I am the one thing standing between you and tea break, and so we're going to make this as quick as possible. But this can only happen with your involvement, okay? My talk, I'm a very simple human. For those of you who know me, I like to think things through quite simply, and so we're going to talk about systems, which isn't my usual jam, right? If you were here last year, you saw me give a talk on ultrasound, and I love talking about ultrasound or physiology or, you know, science. But when I start to think about things like systems, sometimes it's a little bit harder for me. You guys want to turn me down? I feel like I'm feedbacking up here. You guys hearing that feedback or no? Maybe that's just me. Okay, cool. I just don't want to end up in a reverb loop. So there's going to be points during this. You're going to have to, one, pay attention. That's number one. Number two, I'm going to ask for participation. It's going to get super awkward if we just sit here in silence, okay? And I'm just going to stand here, and it's going to be awkward, and you're not going to go to tea. So please cooperate. Here we go. So I got no disclosures. This is where I come from. It's a very different landscape than we're at. This is what one of our critical care bays looks like. That's Minnesota is up here way at the top. We're like Canada South. Maybe we'll join Canada instead of the other way around. And I also used to work here at ARUSHA Lutheran Medical Center up until a few years ago when the landscape changed a little bit. And I worked at a lot of other places. I've been super honored to be part of Muhimbili when the residency started. And you guys know Yash Dubal, that's him. He climbed, look at this ladder. He put it at a 45-degree angle, and he fancies himself a photographer. So he's up there taking a really cool picture of the emergency department, but I think he's going to die on that ladder. And I hang out with other guys like Washira if you've met those folks. But let's start with the clinical case, because this makes us a little more comfortable, right? Like for us, medicine, this is my happy place. So here we go, guys. We have a 22-year-old female with shortness of breath. She's a G2, P2, 2 days, status quo C-section, uncomplicated. She comes in, and this is a case that I was made aware of. Peter and I actually were made aware of, but not directly involved with. She's in extreme hypoxic respiratory failure. Here are vitals here. None of them look particularly good, right? She's hypertensive, she's tachycardic, her respiratory rate is quite fast, her SATs are horrible. Imagine a woman who's just breathing, almost looks like Kussmaul breathing. I mean, she's just breathing so fast, but labored. So what do you guys want to do? This is the part where you have to yell at me. So just start yelling. What do you guys want to do? Good, ABCs, good, I like that. Any other thoughts? I think that's a great thought. Does ABCDE happen by yourself? Yeah, you need a team, right? This is the whole thing. Emergency medicine is a team sport. So yes, we're thinking about our airway breathing, but we need to get whatever team to whatever space it is that we take care of the sickest patients to say, something is not well. So, yeah, I want to activate my team. I want to think about airway. Her airway is patent. She's moving, breathing. I mean, she's moving air, but it sounds maybe like she has coarse breath sounds. They had put oxygen mask on her, and ultimately through her course, because we didn't see her when she presented to the emergency department. We met her later. Someone kind of told us, hey, go look at this person up in the ICU sort of deal, except we weren't managing, and it was an awkward situation between the people that were managing that wasn't us. And ultimately she was intubated, which I think was likely the correct call, assuming you know then what to do with an intubated critically ill patient after you intubate them. Tachy, warm, perfused, you got to get access. So what thoughts do you guys have? I know you have very little information, but just if you're just throwing a differential out there of like, what is happening to this lady? What do you guys think is happening? What are some things this could possibly? There's no wrong answer, right? Like PE, good, right? So she's 2 days postpartum. PE is a really good thought. What else? What's that? Pneumonia, sure, yeah, why not? I love it. So PE or preeclampsia. Remember, there's a decent percentage of preeclampsia occurs postpartum, right? Even up to like 4 weeks postpartum. So let's not forget about that. Is there, so yeah, PE, postpartum cardiomyopathy. Could this be asthma? I mean, it doesn't seem like it, but could be. Pneumonia, preeclampsia, fluid embolism, amniotic fluid embolism, tocolytics. If they have, some people can have adverse response to tocolytics if they were used, but in her case, they weren't. Any of you folks here in the pre-conference? Yeah? Did anyone see any diagnostic tools potentially that could help you aid your decision making? And oh hey, ultrasound. Ultrasound would be pretty sweet. So we do a bedside ultrasound. She has good function. In fact, hyperdynamic. Our right ventricle is not dilated. That gives us some information. She's got diffused B lines. Now here's the magic. It worked. Hey, look. There's a heart that is essentially empty. The right side is not really doing much. The heart is working real hard. On this side, we see those scattered lines that look B lines, so she's wet just everywhere. So now we can kind of work back through this. Right ventricle is normal. We think this is PE. It's a little less likely if the right ventricle is not enlarged. Certainly you would expect someone to have some RV strain if they're hypoxic to 40 and tachy to 150. You'd likely see some, but it shouldn't really cause diffuse B lines. That goes normal, so probably not cardiomyopathy. Asthma, again, not likely. There's B lines everywhere. Pneumonia, it doesn't really fit unless she's just complete ARDS. It's not one lobular pneumonia. Preeclampsia kind of starting to fit some of the bill for me. I mean, it would be nice to have some diagnostics with labs to sort of reaffirm our diagnosis, but it takes a lot of other stuff off. Usually fluid embolism, they're hypotensive, not hypertensive, and there was no tocolytic. So unfortunately, this woman, when Mobula and I were made aware of her, we passed what we found in the intensive care unit was a woman who was intubated, restrained, altered, largely awake, pulling against restraints, bucking the vent, hypertensive tachycardic. And without the, presentations of cases are never about pointing fingers or assigning blame. That's not the point. The point is for us to learn and for us to move forward. And without, belaboring it, this woman unfortunately was subsequently mismanaged and passed away later that day, leaving behind 2 children, including her child that was, 2 days old. So why did this lady die? What do you guys think? No thoughts? Hint, if ever someone asks you a question, ask what kind of talk are they giving? What's the name of the talk? But what are ideas? Why did this lady die? Was it potentially a lack of knowledge, like on the provider's parts? Maybe. Was it potentially a lack of our nursing colleagues or respiratory therapists who were properly trained on vent management? Maybe administrators were pushing ventilation to say, yes, we keep intubated patients, but do we have people that know how to take care of ventilated patients? Maybe we think that all ventilated patients act like traumatically injured patients, head trauma patients. Do they act like metabolically ill patients. And of course they don't. And so we find ourselves in areas where, maybe we didn't have the right medications. Maybe we didn't have an ultrasound. They hadn't done an ultrasound. These are just images I put up here for fun. And so let's talk a little bit of these things. So those are the thoughts I had. I think often we think, or certainly traditionally, you go back 10 years ago, and folks, and even when I was an attending at Muhimbili, I would have my own residents come to me and tell me that the problem was that we didn't have stuff. I remember Bahati. Where is Bahati? There he is. He was my charge nurse at ALMC. And I remember the day, he's running around, he's making that place run like a top. But the day I come in, he's like, we need another ultrasound machine. And I'm like, Bahati, I will buy you an ultrasound machine the day every patient here has vital signs done within 15 minutes and critically ill patients all have IVs started, right? They're very simple things. So we're told often that our issue is stuff. And indeed there are places where shortages exist, right? Where we don't have the antibiotics, where we don't have the IV fluids. But I would say in many of the places that we work, you have access to IVs, fluids, antibiotics, basic things that you can use to start doing the critical care. Use the things that we have. But in the places where we have shortages, yeah, the WHO estimates we have 2 billion people without estimated medications. So shortages are a real thing. Essential equipment and facilities are often worse. Production and distribution, corruption are all issues. And so places give, we worry about stuff, but there's mixed results. We've all seen the EKG machines and ultrasound machines locked, covered in dust in closets, filled with buildings that are empty without providers across the globe. But we're not talking about that. Often we talk about a shortage of educated providers. In this case, I think that definitely played a role. And our previous speakers certainly have talked to the need to educate the next generations of our providers, our nurses, respiratory therapists, physicians. And so certainly we know that 5 billion people are unable to access safe surgical care. Lots of educational needs. And so we go, we educate, and this isn't just those of us from abroad, this is now us, you. I see people giving various courses all over the place. Not that it's bad, but we educate and we teach. But are we teaching the right things? And our Dr. Pokei definitely spoke to that earlier, talking about needing to understand what the needs analysis are. Are we teaching the right things? If I take, say, we're talking a lot about pre-hospital care earlier in this conference. If I take an ambulance, a paramedic educational curriculum off the shelf in the United States, is it teaching to the needs of Tanzania? And I think the answer is not. And so how do we think about understanding what the needs of the local environments are before we go and teach? But we're not talking about that. So why did this woman die? It's obviously multifactorial, and that's what I'm leading. The thrust of this isn't towards that it's stuff, that it's people. It is all of these things, but all of these things are useless also without the system. As Petra was talking about, nurses are often left out. We talk about the physician paradigm. I often joke, people, will go on a trip or something to say, Dunlop's here, so we have an ER doc, so we're fine. And I'm like, what am I going to do on the side of the road or at your house? Like, I'm going to very expertly tell you how much trouble we're in, but I'm going to be completely unable to change the outcome of what's happening. And I feel very similar as a doctor in an emergency department without a qualified nurse. I remember the very first time that I went outside of my place, Hennepin County Medical Center, and I was what we call moonlighting, sort of working in a rural environment to earn money as a fellow. And it was a rural site in Wisconsin. And we had a patient with a problem called a tracheoinnominate fistula, where they're essentially bleeding, hemorrhaging into their trachea from a chronic trach. And this is a very, 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 very bad problem because they can exsanguinate very quickly, but they're drowning in their own blood while they exsanguinate in a place that's very difficult to control. And I will never forget, because the nurse that was there was blood everywhere. And my nurse started waving her hands in the air going, "Lordy, Lordy, Lordy, Lordy," and she ran and then ran out of the room. which very much made me very acutely aware of how appreciative I was of my well-trained nurses back at Hennepin and how much we need a team to function, and by myself, I'm largely useless. So the system failed this woman. So this is a random simple person's definition of a system. We need the people, we need the stuff, the facility, the process, like how we do it. We need the practice, meaning the culture in which, the way we do it, and we'll talk a little bit about that, the implementation and the evaluation of it. So what's the ideal process in the local context? I mentioned about maybe taking that ambulance, that paramedic curriculum, and does it fit? Well, good news, guys. There is a pretty good set of standards of what an ideal process might look like in sub-Saharan Africa. Started with EMFK, I think it's now adopted both by AFEM and perhaps WHO. There are these algorithms. And here it is, guys. You can QR code this. This can be an app for free on your phone. Look it up. It has every major sort of, like, imagine your 40 most common complaints, everything from upper GI bleed to chest pain, so that you and your GPs or whoever's working in your department can have one playbook of how we approach this. It's one safe way to do something. And is it going to be right for every context? Maybe not. But it's a good place to start, and it's based off the best evidence that could be found in the resources that we work in. So we talked about all of that. What about the practice? The practice means the culture. What do we model? Like, what does the team look like? And early on, teaching at Muhimbili, when the specialty literally didn't exist, it's kind of like describing a Picasso painting to someone without actually showing them the painting. Like, what emergency medicine is supposed to look like when you've never actually seen it is extremely challenging. Simulation can be helpful, case debriefing can be helpful, but I think experience is the teacher of all things. And how do we provide that experience? But it's through bi-directional transfer of knowledge. And so we heavily emphasized early on of getting our residents to come and do observerships. And I still host residents, people both from Tanzania, residencies in Uganda, and they that come to Minneapolis and spend months just spending time to see what our team looks like when it works, so they can consider how that translates home. But I'm so proud to say that that doesn't need to be to Minnesota anymore. Now we see residents coming from Somalia to the residency in Uganda, or to the people from Congo taking residency in Dar es Salaam, and vice versa. And we have all this cross-collaboration across the continent, and I think it's just simply fantastic. The implementation requires a local champion, and this is paramount. If you don't have someone who's local, who cares about this will, your implementation of emergency care and the system will never work. Requires a receptive host, meaning the hospital and the system you work at has to be interested in improving and changing their system as they go. And this requires a lot of trust, camaraderie, and collaboration. We need to evaluate, as this was mentioned previously. I'm not going to go into the details, but you certainly need to understand, what did I do? Did it change things? And did it change it for the good or for the worse? Because certainly we have unintended consequences with every change that we make, and we need to understand how and why it works. So here today, I'm to tell you that systems are sexy too, guys. And if you actually want to do emergency care, you need to think less about how to manage CHF acutely, and more about how I make the system, the team, everything from how the patient gets from their home all the way through to their definitive care, and even after the care. And you'll notice that I'm going to put up the fun pictures too that Petra put up. We love this picture. It shows a lot of things, but it also doesn't even necessarily go even after it gets us to inpatient. But then what about after, right? Where's the physical therapy, the rehabilitation, the reintegration? Where's the mental health that was talked about earlier today that affects our patients after something happens? If you're interested in these sorts of slides, they're all free and freely available on the WHO's website. If you Google the thing on the bottom, Global Alliance for Care of the Injured, or GACI, there's an entire slide deck. And it's very helpful at giving you basic statistics and understanding specifically towards advocacy around injured patients and systems work. And lastly, pictures are worth 1,000 words. You may know some of that's Peter sledding up the top. It was part of that. That's Amor, if any of you guys are from Zanzibar and are working down there. And that's Mueller. He's the first in DRC Congo. I do think that systems and making emergency medicine work is all about a family. It's about a teamwork. It's about an ethos. And I would highly encourage you to think about that as you go back to your workplaces and think about how you can strengthen emergency care at your facility. And with that, I will let you go to tea. Thank you very much.
All the speakers, can you come to the stage? Thank you so much, Professor Steve. That was not so much between the tea break, like us and the tea break. It was awesome. Thank you. So the speakers will be coming on stage, and we will have just a few minutes for questions, comments to any of them from the audience. Welcome, everyone.
I think they want tea.
Oh, they want tea.
Any questions or any comment?
Hello, my name is...
And please be brief, okay?
Hello, my name is Joe. I'm from Zimbabwe, Zambia, because my parents come from both countries. Experience is the best teacher. That's what Steve said. So I just want to tell you a short story. I worked in the Congo Brazzaville. We had an emergency. There was unrest in the country, and we were told to evacuate. They gave us 45 minutes to pack everything, and within 3 hours, everyone should be out to the airport and be airlifted. I had 3 kids. It was very distressing. And when you say emergency as a drill, duck and cover, it doesn't mean anything. When it's a true emergency, it means everything to you. So we had to pack, we were allowed to pack only 15 kgs among the 5 of us, my husband, my 3 kids. I didn't know what to pack. I just made sure I had enough food for the child, who was the smallest, she was 2 years, and the rest of the things, I forgot about it. So that's what emergency means. In a hospital situation, we have to be a team to make things happen and to save a life of somebody. So that's my short story. So emergency, when it's real, it is really time. You have to put your time very quickly to make things work. Otherwise, it will not even mean that word emergency anymore. Thank you.
Thank you. I will allow 2 more if... Thank you. There is one back there. Unfortunately, I can't see for some reasons, but one is speaking now.
Good morning. Assalamu alaikum. Steve, I had a question for you. My name is Moiz Adamji. I'm an emergency physician from Dar es Salaam Shifa Pan-African Hospital. If you had to sort out our EMS system in Tanzania, where would you start?
So you're talking specifically about pre-hospital care?
Yes.
It's funny, because we just sat in a meeting yesterday arguing this for about 2 hours, and we came to 0 resolution. It's extremely multifactorial. You know, I think when you're talking about public versus private, and that was, I think, the big distinguishing point, ultimately there needs to be a public mandate. Like, you know, in Kenya, at least when they rewrote their constitution, emergency care, including pre-hospital, was made sort of almost like a universal right, which gave them some leg to stand on to then advocate to improve emergency services as they've started to push for that. You know, in Tanzania, I don't think that's the case. And so, you know, whenever you're asking for, you know, pre-hospital ambulance, ultimately it requires funding. And until there's going to be funding, it's pretty hard to have a universal access number that everyone, regardless of ability to pay, can access, which then totally makes it a non-starter out the gate. So then you start thinking about, well, maybe we start as an exemplar with at least making the private ambulances that exist and wonder if they can opt into coordinated effort at EMS. And I think that's something that we're going to attempt here in the ARUSHA region, and reach out to local stakeholders. We had a number of them, essentially ambulance owners, because there is some pretty good case data to show that as you coordinate your ambulance responses, you actually can increase ambulance utilization, and ambulances sitting in people's parking lots essentially hemorrhage cash. And so if you can show them, yes, you're going to go have other calls that might go to other players, everyone's number of calls are going to go up, community will have more visibility, and hopefully that can help at least create some modicum of regulation and standardization amongst the EMS fleet in the private, and that's at least a start. That's a really challenging question. I really appreciate the question, because I think that's something that this body needs to dig into over the next decade. And I think we're really going to have to wrestle with that at the governmental level to figure out how that moves forward. But I will say that there are great examples locally of systems in Africa that are doing it, and I would highly encourage each other to get involved with. The African Federation for Emergency Medicine has an out-of-hospital emergency care sub-interest group with a very active WhatsApp text stream that you can get involved with and learn how each of these countries is tackling pre-hospital care in their own environments, which I think would be very educational. So, thanks.
Thank you so much. Anyone out there, while I call Dr. Farida on stage for the next part? I don't see any hands. I don't want to see any hands. So thank you so much for your participation in the morning session. We will be giving a small token of appreciation to our speakers this morning, and Dr. Farida will do that. Thank you all for giving us your ears and attention. Thank you.
Oh, thank you very much. Thank you very much.
They are the same, right? Yeah, all the same. Thank you so much. Thank you so
Thank you very much.
for making them.
Can we leave now?
Yeah.
Okay.
So what follows now is the tea break. We're going to spend 15 minutes in the tea break before the next set of the sessions follows. Please let's abide by the time. So in 15 minutes we shall resume for the next sessions. Thank you very much.
Mtazamaji wa SKF TV, kama jinsi unavyoona, hii ni conference kongamano la kwanza ambalo limefanyika siku ya leo na limemalizikia hivi. Tulikuwa tunakurushia matangazo yetu live kupitia YouTube, lakini pia siku ya kesho tutafanya vivyo hivyo, usiondoke. Tumeona baadhi ya wataalamu wa masuala yote ya afya walivyokuja kupresent topic zao na watu wamepokea vizuri. Siku ya kesho tutaendelea kukurushia matangazo, lakini tutakuwepo baadaye tukukupa update mbalimbali ambazo zinaendelea hapa Green Milia. Mimi hapa ninaitwa Pendo Godson, nyuma ya kamera niko pia Godson baba yangu. Kwa heri kwa sasa.
I don't ever slow up, no I don't take shit. I got no love for the fakeness. If you wanna play tough and wanna hate this, I'll always show up and make a statement. I don't ever slow up, no I don't take shit. I got no love for the fakeness. If you wanna play tough and wanna hate this, I'll always show up and make a statement. Everything I do so instinctive and so passionate. Every word I move so descriptive like an adjective. I got a vendetta against people who got it. Being negative when you should be getting after it. I got facts over tracks, this and that, spitting slow.